The next part of the discussion, which is in the chapter in the book, which is central venous pressure, is a pretty common thing that we use in the clinical area, which is called CVP. And central venous pressure, unfortunately, I think, has been simplified to the point that it's a little dangerous. A lot of people think that everybody's been taught if CVP goes up, volume goes up. If CVP falls, volume is dropping. All of you have heard that, right? But that's too simple. You also have another thing that affects CVP, which is contractility. Okay? If contractility goes up, CVP falls. And if contractility decreases, CVP increases. Okay? So those are the two things that you have to make sure that you're always thinking in the back of your mind, that CVP is just not only an indicator of volume, but it's an indicator of contractility as well, how well the heart is pumping the blood out. Okay? Now, the other thing that's a problem for us in clinical for CVP is that CVP, in essence, is really a very bad monitor. Okay? The reason it's such a bad monitor is because it's a very poor indicator of volume change, because the compliance of the right side of the heart is much greater than the left. So in other words, the right ventricle, because it's thin, will dilate without really seeing a change in pressure that's noticeable. So the CVP can actually, even though its volume is increasing, you may not notice a change in CVP at all. Okay? If you're looking at a CVP curve like this is volume in this direction, and this one's pressure. The actual CVP preload curve line looks like this. Okay, so as volume is going up, you're giving another 100, 200, 300, 400, 500 cc's of extra volume. The pressure is not changing at all. It's only until you get to the inflection point here where you start to see the CVP rise all of a sudden. And the next thing that happens is the person's in failure. Okay, because you give a little bit more volume and it pushes the person right over the edge. So in essence, it's a really bad monitor in the adult. In a child, though, you put a central line in them and you monitor CVP, the actual the curve for a child is like this. So what happened between being a little baby, that's up to the age of 3, to all of a sudden now becoming an adult where the CVP doesn't really work very well? When you're born, your right ventricle is actually thicker than your left. The reason that is because the right ventricle has to pump against a high resistive workload, which is the pulmonary arterial tree, which is collapsed. But when you take your first breath, pulmonary vascular resistance falls rapidly and now is much lower than systemic vascular resistance. So the ventricle now begins to hypertrophy on the left, and the right side begins to remodel itself to more the adult form, which takes about the age of 3. So as long as you're putting a central line for somebody that's under the age of 3, then the CVP is actually a very accurate measurement of volume change, because it's linear. Okay, does that make sense? Oh, yes? When you don't have anything else, that's what you use. Okay? In reality, if you're really wanting to monitor volume, you really should put in a PA catheter. Okay, and then you have to do your pulmonary artery occlusion pressures, which of course increases risk. And so people are saying, well, is the person really that sick? Yeah, maybe not. So CVP is kind of good if you're watching it as a trend. Okay, as you're giving volume to somebody, you're seeing that the CVP is really not changing, and that person's pretty dry. Okay, but if you see that CVP begin to rise as soon as you're giving a little bit of volume, back off, because you're going to push them into the failure curve really quick. Okay, and that's what I think people have to be aware of. If you're seeing the pressure rising, you're over here on the inflection curve. You don't need any more volume at that point. You need to do something else if your pressure's not what it should be. Okay. That being said, why is it that we use it? Well, almost invariably when you go into an ICU, your peripheral IV sites get wasted pretty quick. So pretty rapidly we put a central line. And because the central line is so easy to just to hook up to a transducer, we just use it as a guide. It is, and that's what it is. It's really a guide, and a really poor guide at that. But it tells you if you have a CVP of 0, and you see every time the person breathes that you get a negative pressure, that person's pretty dry. That's what we call popcorn. Okay, and you need to give more volume in that situation. Okay, so in that case, it's kind of helpful when you're at 0 or 1. That means you're really kind of too low. If you're at 5, you don't know what portion of the 5 you're in. In 5, you could be all the way from here all the way up to here, and you don't know where you're at. Giving yourself another 500 cc volume and challenge, and you see no change in CVP, then you're on the little lower side of it. If you give 500 cc's and all of a sudden it goes from 5 to 7, stop, because you're on the inflection point. Don't go any further. You give another 500 cc's of bolus to that individual, you'll put them into failure. You'll be 15 or something like that, and then the person will be having pulmonary edema. Okay, so that's what I think you have to understand. Okay. It is a useful tool in a way, but if I really want to monitor volume changes, I really want to have my swan in. And what you're measuring is, what are you measuring really? Are you measuring peripheral venous compartment? You're measuring the central compartment. Okay. So if you look at the two different peripheral blood volumes, looking at peripheral venous pool, which is where most of the blood volume is at. It's found in the capacitance vessels and systemic organs, which we talked about last hour. And your second venous pool is the second area in volume. It's much smaller, and it contains only the great vessels of the thorax and the right atrium. And increasing this volume basically leads to the changes in the preload curve. Okay, if you increase preload, you increase the amount of stroke volume that you generally generate under normal circumstances. Once you meet the other side of the Starling's curve, which is the downside, which is what you don't want to be, then at that point you're beyond that, you're in failure. Okay? Central venous pressure is basically the right ventricular end diastolic pressure, which then correlates with your right ventricular end diastolic volume. Okay, so what does that mean? That means when you generate a pressure volume curve for the right ventricle, this is a pressure volume curve for the right ventricle. Okay. And notice that the pressure here is 20. CVP is a measurement right here. Right 1D, tricuspid valve closes. That would be my right ventricular end diastolic volume, and that correlates across this side to the right ventricular end diastolic pressure, which is equal to the CVP. Okay, that CVP is not a waveform. It is a point in time in that waveform. And that would be right before the C wave. So if I want to be totally accurate with my CVP, I have to look at the waveform and look at it and see where the C wave's at. Now, most of us will just take the line that's there and put the line across, and it gives you the CVP. And that's accurate as long as you don't have tricuspid stenosis or tricuspid regurg. Okay? As long as you don't have valvular failure, CVP can be measured very easily just by looking at where the line is across, because the pressure heights are not that big. Okay? Now, your venous return is how much blood is returning to the thorax from the peripheral vascular beds. Okay? And if you don't return blood back to the central compartment, then the blood to the heart basically empties. Now, can that happen? And the answer is yes. You can have situations where you have a disrupted superior vena cava, and all the blood that's returning back from the head and upper extremities is pouring out through a suction catheter. Or you can have an IVC injury where you're doing the same thing that's coming from the lower extremities. Both the situations are dire, and you don't want to be there. Okay? It's not something that you want to see. But in other words, you may have still adequate peripheral venous compartment volume, but if it's not getting into the central compartment, you can't get anything into the heart, and game's over. Okay? Basically, venous return is basically the rate of which the blood returns from the peripheral venous compartment to the central venous pool. In a stable situation, the venous return must equal cardiac output. So 99.9999% of your life, central venous return is basically equal to cardiac output. Only in really rapidly changing physiologic conditions does that not hold true. But it only holds true for maybe a few seconds, and that was it. So here's a representation. This is your peripheral venous pool. You can see how much larger in surface area it is, okay, in comparison to your central venous pool, which is what is now going to be available for the cardiac output. Okay. Now, what I've simplified this drawing for you in the sense that I've given you the blood returning to the central venous compartment. That blood returning can basically be broken up into superior vena cava, inferior vena cava, and coronary sinus. Okay, those are the three blood vessels that are coming back to the central venous pool. Then that volume is dumped into the right ventricle then pumps it to the left, and eventually gets to be equal to the cardiac output. So this is a very simplified model, but it works just fine for what we're going to talk about. Now, what influences central venous pressure or on venous return is that the venous return depends on perfusion pressure and venous resistance. Under normal circumstances, what happens to venous resistance? What did we talk about last hour? It's pretty much an already dilated state. Okay, so there's not that much venous resistance. Okay, so really perfusion pressure is really much more important. And that perfusion pressure is going to be affected by intrathoracic pressure changes. Okay, so perfusion pressure is directly proportional to the perfusion pressure difference between the peripheral venous pool and the central venous pool. The bigger the delta P, the bigger the venous return occurs. So where do you think, how could you make the delta P get greater? What situation would happen? Take a breath right now. What do you think is happening? As soon as you take in a breath, what happens to your intrathoracic pressures? It decreases. Okay, unless you're breath holding. Now, if you're doing and you're doing a Valsalva, that's different. But if you're just taking a normal breath, okay, your diaphragm's going downwards and it's causing the chest cavitary pressure to become negative. So it becomes a vacuum. So which way is fluid going to go? It's going to pour in. So during normal inspiration, venous return improves tremendously. Okay, which if you think about it, when you're running, I've seen people that sometimes get lightheaded when they run, and I can tell them why that's happening to them most of the time. Most of the time, they're breath holding. They're running and they try to keep in more air by holding their breath. Worst thing to do. Okay? Every time you close your mouth when you're running, you're basically generating a mini Valsalva maneuver because your diaphragm's still trying to go downwards, and it can't now anymore. Okay? So you keep your mouth open when you're running, or just keep your airway open so you don't have that effect. So all of a sudden now your venous return gets actually improved dramatically. Okay? Little things like that can make a huge difference in performance. Okay? But if you do the reverse, if I put positive pressure, I intubate somebody and I put positive pressure into them, what happens to my central venous pressures? They increase. So what happens to my delta P? It decreases. Okay? So delta P can be substantially affected in a negative fashion by positive pressure ventilation. It is very bad to do that to somebody, especially if they're hypovolemic. Okay? If you increase the intrathoracic pressure, then you decrease venous return, so positive pressure ventilation. Coughing with a closed glottis in the Valsalva maneuver, which is why we find so many people dead in bathrooms. Okay? If you worked as a paramedic ever, you see that you find a lot of people in the bathroom slumped over in the toilet. The reason that is because that's when you do a Valsalva maneuver. And if you do that too strenuously, you'll basically inhibit all venous return back to your heart, and you'll go unconscious without you realizing it. Okay? Especially if you cause a vagal effect, which can be caused by defecation. So once you reach a central venous pressure of 0, you don't really improve venous return due to complete collapse of the vein. So you cannot, in other words, by taking in a more vigorous inspiration does not really help you anymore by generating too much of a negative pressure. Once you reach zero inside the actual volume, the vein, it collapses down. You don't really get any more flow returning back. So that's what this is trying to show you. Sorry this didn't come out as well as I wanted to, at least not in the slide. It's in your presentation, came out okay. This is your central venous return in liters per minute, and this is your pressure difference, okay? Where you want to be is right around zero. That gives you the best flow. That's your best venous return is around 7 liters per minute, okay, at zero pressure. So when you see a CVP of 0 on somebody, that's really going to help them get the most venous return back that they can. But once you get below 0, what happens to venous return at that point? It doesn't get any better. So it does not change anymore at that point. It's still fixed. Once you increase your central venous pressure at greater and greater numbers, okay, then your venous return begins to drop off precipitously, okay, which is a way of limiting volume returning back to your central compartment. Your heart doesn't want to dilate any more than it has to. Okay, so it sort of limits how much it's trying to come back. Now, venous resistance is flow. Let me go back up here. Venous return here, which is venous resistance that we're talking about, is another thing that will limit perfusion back to the central venous pool. Now, it's inversely proportional to venous resistance. That kind of makes sense. If your venous resistance goes up, then your flow should drop. That kind of makes sense. Factors that affect venous resistance is the control of tone is mainly via sympathetic nervous system. Norepinephrine causes alpha-1 vasoconstriction, and as a consequence, you can decrease your venous return. There's two differences between veins and arterioles. Okay, veins have very little basal tone, so veins are subsequently normally in a dilated state, and the metabolites have very little effect. Because of their thin walls, veins are actually much more susceptible to physical influences such as breathing, okay, versus the arterioles don't seem to be having that effect. So what you see here, this is your thoracic, intrathoracic now pressure compartment that I just added on. That only affects the central venous pool. You see it does not affect the peripheral venous pool. And then you see the venous resistance here is the next description that I just gave you in this prior slide. Now, what can influence the peripheral venous pressure on venous return? You can increase your delta P, leads to, in other words, you increase your peripheral vascular tone and it improves venous return. The ways that peripheral venous pressure can change will be changes in actual volume of blood contained in the peripheral venous pool. So as you increase the volume, you increase the pressure. What do we do when we give IV stuff, fluids to people? What are we filling it up at? We're not filling up the central compartment unless we have the central line in them. Most of the time, we're filling the volume directly into the peripheral venous pool first. Okay, and an IV peripherally is going into the peripheral venous pool first. Eventually, it gets to the central compartment, yes, but it goes into the peripheral venous pool first. Now, what do we do in the operating room when things are really dire? We actually will put introducers directly into the atrium and dump fluid directly into the central compartment. That's rather impressive when you do that. You can dump large amounts of volume very quickly and get a pressure back almost immediately. Okay, it only takes 100, 150 cc's of volume before you see a rapid change. And you can continue doing that even though the person's hemorrhaging, as long as you continue pushing it into the central compartment. The heart will continue to work. Okay. As you can imagine, that will of course cause a huge dilutional effect because what you're really shooting out now is just not plasma, but it's crystalloid, unless you start giving blood to that individual, which is what you end up doing pretty quickly. The other thing that can also change will be changes in venous tone. Increases in peripheral venous tone increases venous return, and that means sympathetic activation, although that's a very small minority. So what are the things that actually shift the curve to the right? Okay, and the answer is increases in blood volume, okay, which is what we all expect, but also increases in peripheral venous tone. Okay. Shift to the left, going this way, will be decrease in blood volume, and decreased peripheral venous tone will basically decrease your actual venous return. Now, what determinants of cardiac output and venous return, the venous returns we're talking about is to the right side of the heart. This also eventually applies to the left side of the heart because it's a steady state condition between both the left and right ventricles, which must deliver the same amount of cardiac output. So central venous pressure is always inherently driven to the value that makes cardiac output and venous return equal. That's what you're trying to achieve. Okay, so what you end up having is whatever the left cardiac output is putting out, the venous return here has to equal. That should maintain a steady state throughout the whole cardiac cycle. That's what the book's trying to tell you in big words. Okay. Cardiac output and venous return stabilize at the level where cardiac output and venous return curves intersect and maintain this constant flow of fluids moving around. Now, all changes in cardiac output are caused by a shift in the cardiac output curve, which is a change in contractility, which is a very important part. Okay? And in the venous return curve, which is a preload to the heart. As you increase preload, you should accept an increase in stroke volume, which results in an increase in cardiac output. Okay, so, or both. And this is where the part that everybody forgets. Everybody remembers this part. In the venous return curve, they remember the preload. Normal CVP, as it goes up, preload goes up, cardiac output goes up. But one thing that people forget is the contractility part. And what they don't remember is that as contractility increases, CVP actually falls. Okay, and so that offsets that effect. On the other hand, if you see contractility falter, even though volume is really not changing in that situation, what's happened to CVP? It's increasing. So, you know, if you're going by CVP and you just always think it's only preload, then you start thinking of it only as a way of controlling it. If CVP falls, I give more fluid. Okay, if I see CVP rise, then I give a diuretic to get rid of excess fluid. Okay? But in reality, you have to also think about what's happening to contractility. Is that person adequately contracting? Is that person is increasing their CVP from lack of contractility, not so much a volume change? Which is okay still to drop their preload by giving them a diuretic, but in reality, are you really fixing the problem? Are you really addressing contractility issues by giving a diuretic? The answer is you're not. Okay, so it's another thing to keep in the back of your mind when you're taking care of patients in the operating room. And remember, this is your pressure volume curve, where your preload curve is shifting up and down, this portion of the preload curve, and the contractility is here. Okay? When you overlay the cardiac output component with your central venous pool component, okay, this line, if contractility increases, okay, you should see the CVP should fall. In other words, this curve shifts downwards, okay, and causes the CVP to fall in that situation. This is what it's trying to show you here. Okay, cardiac output curve. Okay, if under normal situations, when you have an increase in venous return, okay, you get an increase in cardiac output. So normally, as CVP goes up, cardiac output should rise. So you're going up the curve up this way. Okay. On the other hand, if CVP falls, normally cardiac output should fall as a consequence to that. Now, if you look at contractility lines, they shift back and forth here. If you see that the person's contractility is falling in this situation, what you'll see is that the CVP will actually rise. That individual's number, as contractility drops, has an inability for the volume to empty or leave the heart. So actually CVP rises as a consequence. If on the other hand you see an increase in contractility, the heart is able to empty more fully. So when you come down here to the isovolumetric side of it, your CVP falls in that situation. Okay. So this is what I think the most important part of this lecture is. You have to memorize this portion. This is where the test questions are going to come up. The other ones are graphical representations that make sure that you had a good understanding. But ultimately, CVP can be either looked as increased or decreased. If you have an increase in CVP, it could be high volume, which is all of you should know that already from prior training. But one thing you also have to think about, a high CVP could be from low contractility, or it could be both due to high volume or low contractility. It could be both. On the other hand, if you have a decreased CVP, it could be from low volume, but it also could be from high contractility, or it could be a combination of both. And this is a perfect way of making a multiple choice question to make sure that you think it through and get that question right.